Okay. It's a good thing that I have my version of this here in front of me. Disasters create opportunities to improve care. That's a generally understood concept. It not only applies to the circumstances here with the disaster of 3/11, but is a general idea that is understood. But I wanted to say something even before I get into the main part of my talk about this relationship of disaster to reform. I was reminded in my conversations over the past 2 days with people from Tohoku and thinking about mental health services in Japan, I came to realize that there is a wish to transform mental health care in Japan that goes beyond the disaster and that is moving in the direction of a community-based mental health approach and is moving away from institutional care. And what I was reminded is that 2 disasters in the United States, 50 years ago, in some cases 60 years ago, created the impetus for community mental health services in the United States. And that is, following the disaster of the Great War, we learned that if you treat people who have a stressful response to combat, not by sending them away from the front lines to a hospital, but you treat them essentially in the front lines, remove them just from the front, and you provide support to them, and you feed them, and you make them warm, that you can return them to health much more quickly than if you remove them away and institutionalize them and break the bond with their community. In this case, it was the unit, the military unit, that was the community. So the psychiatrists who returned from World War II back to the United States brought this idea with them and created the impetus for the reform of community-based services in America. In addition, there was a fire in a nightclub called the Coconut Grove in the early 1940s during the war. And Eric Lindemann, a psychiatrist at Harvard Medical School and the Massachusetts General Hospital, went to treat the victims of this fire. And he recognized the importance of connecting to community institutions and to first responders. This was, to many people, a surprise. This was 70 years ago. The idea of working in the schools and the firefighters and the policemen who came to that disaster and working with the survivors helped to form the impetus for community-based services in the United States. In fact, the very first community mental health center in the United States was founded in 1948 by Eric Lindemann, a full 15 years before the federal government provided funding for the first federal community mental health center. And I myself trained in child mental health services at this community mental health center. So let us turn our attention to the lessons from research in the wake of natural and man-made disasters across the world. When I say that disasters create opportunities to improve care, there are many ways that one might respond. The first would be to simply repair what was broken, to decide that what you had before is what you want again, and to repair. But a second level would be to replace what was lost, not an identical form, but perhaps how you would have liked your service system to have evolved naturally from what was destroyed in the disaster. But let me suggest that there may be a third strategy, which is when everything or much is destroyed, it creates a vacuum into which new ideas may flow. And I want to suggest that maybe this is an opportunity to think about how to change the system in a more fundamental way to create something new. Shall we return to the status quo ante, what there was before, or shall we implement some new approaches? My next slide illustrates some of those such approaches that one might consider. I use the language of Health Services Organization to introduce the variety of new approaches one might consider. The first thing most people think about is how can specialized mental health services be brought to bear to help the victims of disaster. By specialized mental health services, I mean care delivered by psychiatrists, psychiatric nurses, psychologists, and social workers. Another strategy that's used in other settings, in other countries, where much of behavioral health care is delivered by non-psychiatrist physicians, what we refer to as primary health care, is a strategy that's been used and a way to think about responses. The third I characterize as a hybrid of health care, which figures out ways to combine specialized expertise with primary care or general medical doctors. Sometimes, in the wake of disaster, we find that there are other institutions outside of the healthcare system that are the most effective actors. They are the most connected to the people who are affected. The schools are a prime example for children, and we will actually hear something about a program like that later in this panel. Finally, I want to mention a very special hybrid service called collaborative care, which combines specialized psychiatric consultation to primary care non-psychiatrist physicians. And at the end of my remarks, I will talk about that in a little more detail, because I think it is useful to have a specific model to think about if that should be the strategy that's decided to use or to move forward with, rather than something very general. If I could have the next slide, I just want to say a few words about how I think about making what I'll call the best choice. That is the best choice for whatever region, in this case Tohoku, and what kind of services you would want. The first consideration is the ability and the willingness of the people and the infrastructure to change. That will address whether you return to what you had before or whether you try something entirely new. Second would be a consideration of the financial resources that you might have available to make this reform. We may dream big dreams, but we have to have resources to make them into a reality. Another form of resource is the human resources. If we wish to have a response that is based on specialized mental health care and psychiatrists, then we must have psychiatrists to do that work. We either have to train them, and we want to train them properly, or we might have to do some other consideration. And last, I've called, with a very American term, know-how, which is an understanding of how to implement change. It goes beyond having the resources. It's about the skill in implementation. My next slide talks about ways of thinking about what I'll call the epidemiology of disasters and mental health. We know that the needs for mental health care will vary by time. They will vary by place. They'll vary by the nature of the disaster. And it's important to recognize that most people do not actually seek services. They do not initiate the care themselves. The next slide goes into the issue of varying by time in a little more detail. Needs will vary by time. During the acute phase, we may see a series of natural responses to stressful situations, to coping with a disaster. These do not necessarily represent pathology or mental disorders. However, during the acute phase, we have to be particularly sensitive to people who had pre-existing mental disorders, because the stress may exacerbate an underlying condition. And I know that in the wake of 3/11, it was very important, with an infrastructure so destroyed, all the hospitals lost in the various prefectures, to recognize the immediate need to deal with people who already had pre-existing mental disorder. It was also important to recognize that there were a range of natural responses that still required comfort and support. Now, in the period after the acute disaster has happened, in the intermediate care period, anxiety and depression will increase. As many as 1 in 3 individuals will have symptoms after only 8 months following an acute disaster. This is a common pattern in many different types of disasters. And then, of course, we're all familiar with having to anticipate the longer-term post-traumatic stress disorder that may occur and interfere with people's lives in a very serious way. As I say, the needs vary not only by time, but they vary by place. Distance is the key variable, but there are 2 types of distance. One is geographic distance from the epicenter of the disaster. In the case of Tohoku, there are 3 epicenters, if you will. One connected to the earthquake, one to the tsunami, and one to the nuclear disaster. They are overlapping in places, but some places have a unique experience. The distance from the disaster epicenter is related to the intensity of psychiatric problems following the disaster. But there is also a phenomenon that I would call emotional distance. The more you are personally affected, you've lost a loved one, you've lost a home, the closer you are to the disaster in terms of destruction and loss, the more you will be affected. We know from particularly disasters related to radiation exposure, from the Chernobyl experience in Ukraine or the 3 Mile Island incident in the United States, that the perception of contamination risk is the key issue. This, to me, is a manifestation of the emotional distance from the epicenter. Needs vary also by the nature of the disaster, and the next slide addresses that. People who have lost life or lost a family member and experience an injury have a different response. It's exacerbated if one also loses their home, either their home entirely, or as in the case of tsunami victims, part of their home is destroyed, and they live in the other part of their home. This is a different experience, one of uncertainty on the one hand about whether I will be able to return home. The other is how safe will my home remain. These things are all part of the consideration of a help giver in the face of a disaster. And then, of course, we have a specific problem if the healthcare infrastructure itself is destroyed, because this was to have been the way we respond. But we've discovered that without a healthcare infrastructure, we have to bring people in from outside. And this was a very dramatic response here in the recent 3/11 crisis, of a quick response from all over to provide immediate aid. So let me review a few of the experiences from around the world. Most of these actually come from the journal that it's been explained that I edit about the delivery of psychiatric services. And I'll just touch on them for what they can offer us.